I was asked to talk about clip versus coil or decision making for the treatment of aneurysms. I don't have any disclosures. Aneurysms are relatively common, as Dr. McDougall was going on discussing earlier, and it's higher in certain populations, up to 10%. Still, in 2017, ruptured aneurysms carry a poor prognosis, and only the minority really who survive a subarachnoid hemorrhage recover completely. There's about 31,000 ruptures per year in the U.S. now. In terms of when I think about decision-making for aneurysm treatment, I think it's important just to quickly review the tools we have, and some of them have been discussed. I think if we look at what's happened with microsurgery versus endovascular advancements have kind of happened exponentially, whereas there's been only very modest improvements in microsurgery, at least in my mind, over the past 2 to 3 decades. So a major advance was the introduction of aneurysm coils, the GDC, this publication back in 1991, which really introduced detachable coils in our armamentarium. Dr. Monteith reviewed the type of coils. We have many types of coils these days with different shapes. Some have coatings, for example, expanding gel coils and so forth. And the technology for coils has improved dramatically. I think we've discussed some of the stents, and Dr. McDougall is going to talk about flow diverting stents. Let's see. Flow diverting stents in a minute, but we have many different types of stents that are pretty easy to deliver now. And there's been improvement in balloon technology as well. We talked about balloon remodeling, but we have these compliant balloons which can help us to coil even some wide-necked aneurysms. I think Dr. Patel is going to talk about some of the emerging technologies, but for example, and this is not available quite yet, but we have these new sort of aneurysm bridging devices and intraaneurysmal flow diverters, which we'll only just mention briefly. And these will be able to help us handle sort of wide neck bifurcation aneurysms, where currently we're either treating with surgery or sometimes with the so-called Y-stent configuration or the double barrel configuration with stents side by side. I think if we look at microsurgical technique and what tools we have available, I think that we've been more cognizant of trying to do surgery safer and gentler. There's been a movement towards retractorless surgery, using only dynamic retraction with the suction, for example. We've developed more complex clipping techniques for aneurysms that are atherosclerotic or very broad-necked. And then for some complex pathologies, bypass can have a role, and I think Dr. Monteith will be talking about that tomorrow. But for the right case, bypass can have some role. There's no question that there's been, in general, a paradigm shift towards endovascular therapy. And I'll just review 2 of the important studies that have sort of shepherded that transition. One of them was ISAT, and that's been briefly mentioned. But this was a study that compared clipping with coiling for patients with aneurysms deemed suitable for either treatment. And so, as we'll discuss in a minute, this is in contrast to the BRAT, the Barrow ruptured aneurysm trial. Only about 1/5 of patients who were screened were actually enrolled in this study. And it basically looked at the incidence of death or dependency at 1 year as the initial outcome measure. And the publication of this study really changed how people thought about the treatment of ruptured aneurysms. The main conclusion was that in coiled patients, 23.5% were dead or dependent at 1 year versus 31% in the surgical group. And, this spread throughout the media, and I think was a large driver of the paradigm shift, at least for the treatment of acutely ruptured aneurysms. There are a lot of criticisms about this study. Namely, it was, primarily a European study, that many patients were excluded, that the surgical results were overall poor, that there was no criterion for surgeons who could perform surgery in the study, etc. But there's no question it really changed the treatment of acutely ruptured aneurysms. The other study Dr. McDougall was the lead author on was the BRAT study. And this was different, and I'll only just briefly go over this for a minute. In the ISAT, the model for the ISAT was basically this pre-randomization model where patients were randomly allocated, was this model here where patients were deemed suitable for either option and then randomized, and there was few crossovers. But the BRAT study really tried to bring all patients in, and patients could cross over, so it was a different paradigm in terms of study. And there was 238 patients assigned to clipping and 233 patients assigned to coiling. And crossover was allowed, as I mentioned, and its primary outcome measure was also look at death or dependency at 1 year, and then there's been subsequent follow-ups. This reflects the amount of crossover that 62% of patients assigned to coil actually received coiling, and that was as an attempt to include as many patients as possible in the study. But similar results, though, to ISAT. 23% of patients in the coil group were dead or dependent at 1 year compared to 34%. And so it had similar, at least at the 1 year time point, results as the ISAT study. And I'll just say that this was also an important study examining the treatment of ruptured aneurysms and basically lent credence to the ISAT study. And I think that this was also a contributor to the shift in preference in terms of treating acutely ruptured aneurysms with coiling. This is something, this is looking at discharge data, so it's flawed, obviously. The number of aneurysms hasn't gone up so much. But this was the publication of ISAT here, and you can see that the number of coiled aneurysms in terms of discharge has increased, and the number of clipped aneurysms has modestly decreased over time, but there was a shift in aneurysm treatment to endovascular therapy. So to get into the decision to clip or coil, I think the bottom line is that the overall treatment goal for an individual patient is to treat that patient's aneurysm with the safest, most effective and durable treatment that can be applied with the lowest risk. So it's not really a competition of clipping versus coiling. We use different tools to treat the same condition, and really the competition or challenge is looking at what all treatment modalities versus the aneurysm, either applied as a treatment team with different specialists or by the same person who does the various modalities. So microsurgery, just briefly, we know that it's durable, we know that it's effective, and we have very long-term data establishing both durability and efficacy. Its limitations are that it is more invasive, clearly, than endovascular treatment. There's some element of brain retraction, although we tried to move away from fixed retraction. It's difficult to access certain locations, for example, the posterior circulation, and of course perforator injury and cranial nerve injury because we're working exovascular or outside the blood vessel. For endovascular treatment, the advantages are it's less invasive, recovery is generally quicker, it has an excellent safety profile, and efficacy appears to be pretty good, even with longer-term follow-up now. A concern that's always raised against endovascular is that recanalization and coil compaction can occur. There's been reports, although much less common now, hemorrhage after apparent complete occlusion. Wide-necked aneurysms remain a challenge. MCA aneurysms with incorporation of the vessels into the aneurysm itself. And giant aneurysms, those are really a problem still for both microsurgery, at least in my mind, as well as endovascular treatment. So in terms of patient selection, I think about it looking at several factors. One is patient-related factors, so looking at age, and not just chronological age, but perhaps physiologic age. We know that patients with many comorbidities at a younger age are different than otherwise healthy individuals. I think clinical grade is important for ruptured aneurysms, comorbidities, and life expectancy, especially when you're considering treating unruptured aneurysms. And then I think about aneurysm-specific factors, size, location, which we'll get into in a second, neck width, dome to neck ratio, presence of calcification. As we know, that can make surgery more difficult because the clips have it's more challenging for the clips to close completely if there's calcification and atheroma at the neck. Presence of thrombus, which can apply to both coiled and clipped aneurysms. Incorporation of vessels into the aneurysm, and in multiple aneurysms. For example, if patients have aneurysms that are located in two different vessel territories, a craniotomy may not be the best option if it would require bilateral craniotomies, whereas endovascular, we may be able to get both at the same time if we're not able to identify which one hemorrhage in the case of a ruptured aneurysm. And then, of course, more commonly, especially as we see patients as second and third opinions, patient and family preference, patients may have a preconceived idea. And believe it or not, some patients want surgery. They're fixated on getting it fixed and not having to worry about it. So just some generalizations. I would say that at most centers, but not all, basilar bifurcation and most posterior circulation aneurysms are treated endovascularly. I think at many centers, middle cerebral artery aneurysms are treated with microsurgery. Although it's center dependent, there's some centers that believe in why stenting a lot of MCA aneurysms. And then other aneurysms are, in terms of treatment, selected on a case-by-case basis, with coil embolization recommended preferentially for ruptured aneurysms that are at least suitable for treatment with either method. I think one thing, and this was alluded to earlier, if you're going to stent an aneurysm in the setting of acute subarachnoid hemorrhage, as we all know, that requires dual antiplatelet therapy, at least with current technology, and there's an increased risk of hemorrhagic complications, I think, especially with CSF diversion. So if you're contemplating treating acutely ruptured aneurysm with stenting and you're planning to coil it with the stent, then put in your ventric before the procedure, and then you have to worry if they need permanent CSF diversion with giving platelets and temporarily stopping the aspirin and Plavix, etc. So that just is one factor to consider. But sometimes stenting in the acutely ruptured setting is the best thing to do. So we'll go through just some case examples and maybe get some comment on some of these cases at least. This is a young patient, about 45 years old, that has subarachnoid hemorrhage, typical ACOM, and it has some type of neck, and there's a shelf, as Dr. Monteith was saying, but it's lobular and so forth. And I agree with what Dr. Monteith was saying at the start, that the simplest solution is usually the best solution, and with current coils, with their shapes, this was treated just primarily with coiling, and it was fine. And I think that the coil technology has improved so much that simple coiling for a little bit odd-shaped aneurysms can be done effectively. There's no balloon or anything like that. This was a 27-year-old patient that presented with seizures, was working on a golf course, and you can see that there's some type of mass located surrounding the sylvian fissure with some calcification. And this was the aneurysm shown here, and I may have a 3D view. And I'll just ask, Steve, what do you think about treating this aneurysm? No, it's all M1 segment. It's strictly M1 segment.
People have treated these with both doing stents and coils. Done. There was perforators getting covered with pipeline. Certainly, prognosis.
Okay. Yeah, that's what I had recommended, and the patient refused surgery. And so we ended up doing what you had said earlier with stenting and then coiling the aneurysm. And I don't know, this was done a while ago, so maybe he'll be following up at UVA. And I'm not sure what type of recurrence there'll be, so you can stay on the outlook. That was about 8 or 9 years ago. That was, I think, the 6-month follow-up. It looked fairly decent. Another thing that we had talked a little bit about, and Dr. Monteith illustrated a nice example where why stenting can be used. When you have a wide bifurcation aneurysm, wide neck bifurcation aneurysm, and this one's fairly wide here, you can place a stent out one PCA down the basilar and then out the other. And I think with technology that, you know, we can go across the top of the basilar by coming from the carotid through the PCOM, and that will allow a complete reconstruction without having the extra metal of 2 stents. And, you know, that was what was done in this instance. The stent can't be seen, but it goes from between the arrows, and that allows a pretty nice coverage of the neck. I think with, for example, the Elvis stent, you can sort of question mark it or put it up where it may cover better than that. And then another example here that was done with the same, but this may be something in the future where an intraaneurysmal flow diverter or one of the devices designed for bifurcation aneurysms could be used. I think another thing, and I'd like to get the opinion of some in the audience, this was mentioned here, Dr. Kalani had mentioned it, and Dr. Monteith showed an example of a blister, but these are some, at least in my hands, these are some of the most difficult aneurysms to treat. These are aneurysms that arise on the, well, you can label it however you want, but the side opposite the takeoff of the PCOM, I call this dorsal wall, and it arises on the same side as the ophthalmic, but usually at around the level of the PCOM or the anterior choroidal. And these are, as people know when we operated on them, that this is, the carotid tends to disintegrate when you expose these aneurysms because they're a true pseudoaneurysm. And then you're looking at the inside of the carotid. And we have done, at least I've tried different things, clip wrapping, Sunt keys clips, trap and bypass, in the old days, overlapping stents, and more recently with flow diversion. But I know, for example, Dr. Caldwell is a big advocate of open surgery for these aneurysms, and others are as well. But I think that, at least in my hands, that I think there's been a shift towards treating these endovascularly. The concern being with that is that you're using dual antiplatelet in the setting of acute subarachnoid hemorrhage. So any comments from the faculty on these aneurysms, on how to tackle them in 2017?
So, I mean, I had a patient very similar to my first practice, and I used a flow diverter, and like you said, the issue with platelets treatment so regular hemorrhage, especially if they or, you know, surgery back here. More recently, and I wish I had this ratio when I first started, is the IV antiplatelet form, and that instead. So, you know, IV ticagrelor, and then outline of 6 minutes. So you put a Vertrigan or something else for hemorrhagic complication. These are different cases that have been developed of considered 9 minutes from seeing inside the province. I've moved towards
Okay. Okay, we'll move on. I think a main point is just to recognize that this type of aneurysm is a different beast than a typical saccular aneurysm. I think a great indication for endovascular treatment is when you have recurrent aneurysm after clipping, if it's suitable for endovascular treatment, because reoperating, which we have to do from time to time, is much more difficult. An endovascular solution can be a good solution for recurrence, which fortunately is not that common following clipping, like in that case. I think another thing, we talked about how MCA aneurysms generally are treated with microsurgery, but also there's some patient-specific factors that we went into. So this was a patient who had terrible neurogenic stunned myocardium, had an EF of about 10%, or was really, really sick and had this aneurysm. And I just quote my old mentor, Dr. Jane, who was quoting W.H. Auden. He said, "Prohibit sharply the rehearsed response." So this aneurysm was treated with coiling because the patient was too sick for surgery. And so just because it's an MCA aneurysm, there sometimes can be an endovascular treatment as well. And when patients are really sick, endovascular treatment can be a really good solution under tough circumstances. In my mind, roles for microsurgery in 2017 include complex aneurysms that are wide neck, involving branches at the base or requiring reconstruction or bypass, ruptured aneurysms with hematoma, endovascular failures that may be difficult to salvage with further endovascular treatments, potentially young patients, with the concern being long-term durability and unruptured aneurysms, and of course patient preference. So I think this is a good indication for surgery when there's a large clot, and you can see the aneurysm projecting into the hematoma. But for these type of aneurysms, I generally go in and partially decompress the clot, and then go transsylvian and expose and clip the aneurysm, just because I'm much more familiar with the anatomy going transsylvian. Of course, I think everybody has heard of the superior temporal gyrus approach, where you go in through the superior temporal gyrus and then find the aneurysm through the temporal lobe into the sylvian fissure. But I'm just, I probably would get a little bit disoriented doing that. For sake of time, I'm just going to move past that. And I'm going to move past PICA aneurysms because I'm going to talk about those tomorrow. One other thing I wanted to address, and so we've talked about sort of the big things in decision making, but I'll talk about a couple of areas of controversy. I think one area of controversy potentially is with large and giant paraclinoid aneurysms that present with visual loss. The concern being, surgery can be difficult for paraclinoid aneurysms. It requires usually exposure of the neck. And then coiling, when you already have pressure on the optic nerve, for example, adding more coils or a flow diverting stent and more coils, I just don't know, because I've seen visual outcomes go either way with that. So I just put that out there, that I think that it's very feasible to use flow diversion and coil or stent coil these aneurysms. Sometimes, vision stabilizes, sometimes it improves, but sometimes I've seen it deteriorate some. And I think that I'm not sure what my thinking is on this. There's a patient who was thought to have a pituitary tumor. Fortunately, it wasn't biopsied because they have this large aneurysm sitting in the sella. And this is one where we decided to operate on it, and it's a little difficult to see, but we just reconstructed it with multiple fenestrated right angle clips, reconstructing the supraclinoid carotid, and then punctured the aneurysm at the end, but didn't dissect it off the optic apparatus. And the patient had returned to normal vision, and that may have been the case with a flow diverter, maybe with some coils. But I think that, at least in my mind, I'm not sure what the best treatment for these type of aneurysms are. in 2017. And Dr. McDougall is going to talk about flow diversion. One thing on cavernous aneurysms, I think that there's almost no role for microsurgery with cavernous aneurysms. The exception being is if you try to get through an aneurysm like this and you can't get to the other side in order to place a flow diverting stent, then there might be a role for, if it truly is symptomatic or life-threatening because it's hemorrhage, which happens rarely, you could be pressed for that. But I think that there's currently not much indication for that in 2017. I think sometimes we can use all the treatment options to handle an aneurysm for a given patient. This is a patient you can see with subarachnoid hemorrhage quite a bit in the posterior fossa. And this is a case I did quite a while ago, but there's an aneurysm that arises from PICA. I don't know why the CTA is a little bit grainy here, but it actually arises from left PICA, but it's actually located to the right of the brainstem, as is shown there. And this is the angiogram here, and it's fairly broad-necked, incorporating PICA into the vessel itself. And as I said, it was located anterolateral, actually to the right side of the brainstem. So in my mind, this would be difficult to clip reconstruct. I think looking at this, PICA comes right out of it. And at the time, I thought it would be really quite difficult to treat endovascularly. So I opted, and again, this was a while ago, to do a proximal vessel occlusion, and I did an occipital PICA bypass at the time. And I'll just skip through the movie, but this was, I took the patient to the OR and did this bypass and then took them straight to the angio suite, or it could be done in a hybrid room, and coiled off the aneurysm here. And then the bypass filled the territory, including back to the lateral medullary segment, where some perforators can arise. I think another reasonable indication for using multimodal therapy is if, for example, in this patient who has a large subarachnoid hemorrhage in the posterior fossa, has a basilar bifurcation aneurysm, but a larger PICA aneurysm, and the source of the hemorrhage is not clear. And I think that this aneurysm actually had some clot in it, the PICA. And so we opted to coil the basilar bifurcation aneurysm first, and then we took the patient to the OR to clip the PICA aneurysm. And maybe we could have coiled the PICA aneurysm, but as I discussed tomorrow, that sometimes that can create difficult recurrences. And we'll, as I said, we'll get into that a little bit more tomorrow. So sometimes we can treat a same patient with endovascular and open surgery to try and help their problem and prevent rebleeding when we're not sure. This patient here, young kid, presented from a rural town with really bad headaches, had NF1, and has this posterior circulation aneurysm, a giant, it involves the, I guess it involves the VB junction in the basilar trunk, and you can see that the distal vessel is dysplastic all the way up, and in addition has this with his cervical carotid on the left side, giant cervical carotid aneurysm and petrous aneurysm. You can see that there's a large PICA collateral here. And just for time's sake, we thought about different things. Maybe this would be a good case for a pipeline and then coil off if that makes sense. So do a pipeline that extends from here down into this vertebral artery and then take the inflow from the other side. And this also case was from a while ago. And what we had decided to do was do a staged proximal vessel deconstruction, so classic Hunterian ligation, or as Dr. Drake had done previously. And we staged it by starting to occluded this side here. And that prompted the patient actually to come back with a subarachnoid hemorrhage. And so we were forced to take the other one at that time. This was probably around 2010 or so. And then this is what it looked like. We ended up taking this one at the first setting, then came back with a hemorrhage, and then we coiled the aneurysm and then took the other PICA. And his whole posterior circulation fills from the PCOMs down to here, and he had done quite well from that. The only problem with that is now you have two carotids filling the entire brain, one of which has these giant aneurysms of the cervical and petrous. And I think at that time, and this sort of illustrates, there was some mass effect on the brainstem that you can see here. And in follow-up, actually, after the proximal vessel occlusion, it went completely away, even with that amount of coils. But then he came back, and I think I was in Philadelphia at the time, but this started to enlarge, and it was getting larger up into the petrous, and now there was quite a large petrous. And then the question is what to do about this now. And we went back and forth on a number of things, and but ultimately he actually passed a test balloon occlusion on this side, so that means that his entire brain would be filled from one carotid artery. But we decided to do, this is what we decided to do, just to sack that carotid and then construct a radial artery bypass, with the thinking being that this bypass would help to reduce flow up his only carotid artery, which was his only normal vessel at the time. And I think that overall he's done pretty well from this. That was him shortly after the surgery. I just want to, in the last few minutes here, I wanted to just make a couple of general comments that are not entirely related to decision making. But this was a patient who came in with a small subarachnoid hemorrhage. You can barely see it in the right sylvian fissure here, and had a PCOM aneurysm that was coiled, and then interestingly had two other aneurysms, had a intercoroidal aneurysm here, and then had this MCA aneurysm over here, and was lost to follow-up for about 5 years, and then came back with a pretty large new subarachnoid hemorrhage. And this is what was found. Statistically speaking, from the data we have available, it should have been one of the other aneurysms untreated on the left side that ruptured, but it turns out that in retrospect, at initial presentation, there probably was a slight bump on the carotid artery here, but in 5 years had enlarged into this aneurysm at the carotid terminus or bifurcation with a pseudoaneurysm. So I think for decision making in the future, we have to have a better understanding of the basic biology of aneurysms, and perhaps that this will facilitate patient selection and to develop novel therapies. There's some exciting work being done in this area. For example, David Hassan and others, for example, at the University of Iowa, are looking at non-invasive MR imaging to look at inflammation in the aneurysm dome using ferriamoxitol, I think, which is something that's taken up by macrophages and may help to predict which aneurysms are active and may help to guide therapy for unruptured aneurysms. But I think that there's a lot we don't understand, and a lot of patients don't follow the rules. And one final thing, just to leave everybody with, is we have this situation where endovascular treatment has become much more common and accepted and desired treatment for patients with aneurysms. But then we have cases that still aren't suitable for endovascular, and how do we train the next generation of vascular neurosurgeons so they can tackle aneurysms microsurgically? And I don't know the answer to that, but I'll share some thoughts. So resident duty hours have been reduced throughout the world. I think the most severe restrictions are in the UK, but it's happened throughout the world. And that means that residents may not have opportunity to scrub for cases. You know, and I understand the rationale behind duty hour restrictions, but it's become a fact that training has, I think, become more difficult for certain types of cases. And, we know the number of open surgeries has decreased, and the ones that go to surgery are more complex and difficult. And so some of my thoughts are, and there's some data showing that the volume of centers correlates with outcome. So it might be to concentrate aneurysm treatment in high volume center. One of the problems with that is that in general, vascular neurosurgery and its associated stroke is very profitable for hospitals, so hospitals want to have this done even if they're not doing a high volume. I think that maximizing educational experience afforded by open aneurysm surgeries. So this might mean doing 3D printing and doing simulation, taking a case before and having residents and fellows walk through the case and doing the surgery before they actually hit the operating room. Simulation and microvascular training just in general. One thing that was very useful to me, I was what Dr. Jane used to call a rat doctor, where I did a lot of surgeries on animals as part of research, and that helped, I think, to some extent with learning microsurgical technique. And I think fellowship training is mandatory. Of course it is for endovascular, but for open vascular as well. And I'll stop with this case. This patient came in with terrible headaches, was unruptured, and has this carotid terminus aneurysm that appears to incorporate both the MCA and the ACA at its base. And I didn't think that there was a good endovascular treatment or solution for it. There was an ACOM, but it wasn't great, just as part of the decision making. And so I took the patient to surgery, and we clipped the aneurysm. The surgery went okay, and this shows the intraoperative angiogram. The MCA is patent, of course, but the ACA doesn't fill antegrade. This is the contralateral carotid injection, and you can see that this ACA A1, this fills back to the A1 down to the clip, and I tried to readjust the clips and so forth, but I could never get the ACA to fill antegrade. And I stopped because I was worried we were going to have a complication from that. And the signals were good, and the patient woke up fine until post-op day 2. We sent the patient out of the ICU, and then she was walking to the bathroom, became hemiplegic, and you can see that the initial CT shows that there's a small infarct around the caudate head and the capsule, and she ultimately deteriorated and developed a big ACA infarct shown here, and she did poorly. So I took a patient with an unruptured aneurysm, and they left the hospital disabled as a result of my surgery. And I think just in closing, the message I would leave is that it's important, and I'll quote Dr. Drake here, it's important to look at your complications and try to figure out if you could do it over again, what you would do differently, what you would do better, what lessons you could pass on to others. And I think in this case, maybe I should have opened up the aneurysm, and maybe I had knocked some clot into the A1 segment, but in retrospect, I had to keep the A1 open antegrade, and that probably would have avoided this, because I think it was thrombosis of that ACA because it wasn't getting antegrade flow, and I knew the ACOM was not great. But Dr. Drake said this was in his book that he published on, I think, 1,767 vertebral basilar aneurysm surgeries. If only we could have back again many of those who are lost or badly hurt for a second chance in the operating room or endovascular suite with what we have learned. So I'll stop there and take any questions.